Okay, now we are moving on to chapter 9, and this we get to talk about the musculoskeletal system and the disorders that can come along with that disease or that system. And so, first, for an overview, let's review what the musculoskeletal system is. And basically, skeletal would be bones, right? And so the bones are going to be classified by shape. There are long bones, short bones, flat bones, and irregular bones. And a bone itself is going to have bone tissue, that consists of the matrix, the mature bone cells, which are called osteocytes, bone producing cells, which are osteoblasts, and bone reabsorbing cells, which are osteoclasts. So bone, what is bone? Well, we have types of different bone tissues, and we have the compact bone, and this would be the outer covering of the bone itself. And we have your cancellous, otherwise known as a spongy bone, and this would be the interior of the bone, and it's kind of like a lattice work, and so it looks like a sponge, and that's why it's called spongy bone. And so you also have other bone structures, and this would be like your periosteum and your endosteum. Your periosteum is the connective tissue that covers over the bone, where your endosteum, again, the inside endo, right, is going to be that lining that is rich in osteoblasts, and it lines the medullary or that center cavity. So looking at the structure of the bone, this is figure 9.1 on page 163. You can just look and see all of the anatomy we just talked about. We have the periosteum. The osteum is a little subset here, which includes your caniculi as well as your lacunae, which are going to be where those osteocytes are going to reside. You have your Haverson canal, and then you have the laminae. And again, that's all part of the osteon subunit. And then in the bone itself, again, you have the osteon of the compact bone, which again is this, except for this is increased. That's the smaller one. You have the trabeculae of the spongy bone, so that would be like the lattice work there. And then you have a Haverson canal and a Volkmann's canal. Okay, so we're going to talk about all of these coming up, but that would be the overall structure of the bone. And again, that's on page 163. So what about the long bone? Well, you have your ephysial, like ephysia, whatever. So ephysis, and so this would be like if it talks about the ephysial plates, right? That's what it's talking about. You have your diaphyses, and then you have your epiphyses. Okay, so you have the two ends, and then you have the middle. And then looking at the other substructures, you have your articular cartilage, you have your ephyseal line, you have that spongy bone that we just talked about, you have your compact bone, as well as that medullary cavity, right? You have the nutrient foramen, so that's like a foramen as a hole. It's a fancy word for a hole, and that's like where your blood vessels are going to go in so that you can actually give your nutrients. You have your endosteum and your periosteum as well, and these are all in the diaphysial area. So what about skeletal muscle? Well, skeletal muscle is pretty important, and it has like some pretty awesome functions, like they keep us moving and standing, right? And so the skeletal muscles are going to facilitate body movement as well as maintain body position. They're going to help to stabilize our position, our joint, as well as produce heat to keep us warm. Okay. So what are some characteristics of the skeletal muscle? And the skeletal muscle chapter outline area is on page 164. So usually skeletal muscle is under our voluntary control. What that means is I can tell it to move when I want it to. So I can say, move your finger, move your fingers, right? And because that is voluntary, I'm asking myself to do that. Skeletal muscles are bundles of protein fibers that are covered with connective tissue. And these are well supplied with nerves and blood vessels because they need those nutrients. Stimulation occurs at the myonal junction, and the myoglobin is going to store oxygen in our fibers. So remember, hemoglobin's our transporter, where myoglobin is going to be the one that actually stores the oxygen in our skeletal muscle fibers. Glycogen can also be stored here for energy. And we also have skeletal muscle attachments. And these attachments are attached directly to the periosteum or by a tendon. And cells do not undergo mitosis after birth. So after we have them, we have them. So looking at the connective tissue coverings, we have your epimysium, your perimysium, and your endomysium. And so the epimysium is going to be that connective tissue that surrounds the entire muscle, where your perimysium is going to be the connective tissue that surrounds the muscle fascicles. And then your endomysium is going to be the tissue that's going to be around the individual muscle fibers. So again, those are great flashcard words. So what is skeletal muscle? Well, we have a motor unit, and this is where you have the motor means movement, right? And so motor neuron is in the spinal cord, and then all the muscle fibers that are innervated by the neurons is considered to be a motor unit. So the motor neuron and then the other things around grouped together are going to be that motor unit. Then you have your neuromuscular junction. So break those down into your key words. Neuro means like brain, nervous system. Muscular means muscles. And then junction is where they intersect, right? Where they join. And so the neuromuscular junction is going to be the synapse, which is a fancy word for like joining, right? Between the motor neuron nerve fiber as well as the muscle fiber. So again, where your nerve is going to be joining with the muscle. And you have a couple different chemicals that are important for this. The most important one is going to be a neurotransmitter, which is called acetylcholine, and that is abbreviated ACH. We have the breakdown of acetylcholine by a cholinesterase, and so it's called acetylcholinesterase, if you want to be very technical. And then you also have anticholinesterases, and these can interfere with the breakdown of acetylcholine by interfering with the acetylcholinesterase, right? So remember, enzymes are named for what they do, and enzymes are specialized proteins that end in ACE. And so if it's an anticholinesterase, then it's going to stop the function of the cholinesterase, which is breakdown. So always look for those root words because that's really going to help you in science in general. So what about the neuromuscular transmission and muscle contraction? Well, this is what happens when you have the arrival of the action potential. And so what happens is that we have the presynaptic terminal is going to be depolarized, right? And then that's going to cause, and polarization is just like a channel, right? It's an electricity differentiation. And so you're going to take that away from the arrival of the action potential, and that's going to cause the influx or a significant increase of calcium into that area. Then you have exocytosis of the neurotransmitter. Remember, endo is in, exo is out. And so this is going to cause an exocytosis or an exiting of the neurotransmitter, which again is that acetylcholine. Then this neurotransmitter, which is acetylcholine, is going to diffuse or travel to the postsynaptic receptors. So again, look for those root words, postsynaptic. So that's after the synapse, there is a little area and there are receptors there, and that would be called the postsynaptic receptors, and these are going to be those attachments. And then we have a general generation of a muscle action potential. So it's like, yep, we have all the checkpoints in, let's fire up the engines, guys. And then what happens then is during the action potential, we're going to release calcium from the sarcoplasmic reticulum where it's stored. And then this is going to cause a power stroke, and that would be the contraction of the muscle fiber. So think of how fast all of this happens. I'm going like this, and that's a gazillion different neuromuscular junctions and, neurotransmitters that are going off, etc. These are all happening in microseconds, and that's why your body is so absolutely amazing. So looking specifically at that neuromuscular junction, again, this is figure 9.2 on page 164. And so it says a neuromuscular junction. And so in this is saying a nerve impulse, which is the action potential, travels down the axon terminal. The impulse is going to cause the release of acetylcholine. Okay, so right here, acetylcholine, nerve impulse comes in, right? And then the neurotransmitter is going to diffuse across that synaptic cleft. And the cleft is just like a space, right? And then that's going to stimulate the muscle fiber, okay? And then, so you can see this is just what we talked about just in picture form, right? So the nerve pulse is going to go in here. It's going to cause the neurotransmitter to be released, right, with acetylcholine. And then those acetylcholines are going to be received by the synaptic cleft, okay? So what about joints? Well, joints are pretty important, and this is on page 166 of your book. And so this is where we have a connection between bones. And this is accomplished by tendons and ligaments. And your joint itself has little blood supply, right? And so this is why if you have a joint injury, the healing is going to be rather slow and actually kind of difficult, okay? Because we don't have a good blood supply to deliver those nutrients or to take away any debris that happens to be there. So we have some different classifications, okay? And so these would be, again, under joints on page 166. You have synthroses, and these are immovable. And so an example of this would be your cranial sutures. So you know how when you're born you have that little hole? It's like the open foramen. And but then our skull is going to start fusing together. I can't move my skull, it's fused together, right? And so that would be an example of the synthroses. Then you have amphitheroses, and these are slightly movable. And so this would be like an example of your ribs to your sternum. Okay, unfortunately, if you have to do CPR, right, your ribs can kind of flex a little bit, and so that's an example of that. And then you have your diathroses, and these would be freely movable joints. And so an example of that would be your shoulder, okay? So I can freely move that. Specifically talking about your synovial joint, these guys are really important because it can cause actually the synovial joint is where you have lubrication, and it's a very important part of the joint system. And so you have your articular cartilage, and this is going to be the covering over both ends of the bones. You have your synovial membrane, and this is going to produce the synovial fluid that's going to fill that space between the bones. You have your articular capsule, and this is going to be consisting of that synovial membrane, and this is a fibrous capsule. You have your ligaments, and these are going to help to reinforce that capsule by linking the bones and supporting the joints. You also have menisci, and these are lateral pads in some joints that help to stabilize it. And then you also have the bursa, and these are fluid-filled sacs that can add extra cushion. And so your synovial joint has a lot of components, and it's very important to keep everything moving. And so this would be an example of a normal synovial joint. So you can see that there's like the area between two different bones, right? And so that's the synovial area, the synovial joint. You have your joint cavity with your synovial membrane. You have the synovial fluid, which is going to act kind of like your cushion. You have your articular cartilage, which makes sure that it stays where it's supposed to stay, and all of that jazz. So this is on figure 9.10 on page 177. And I'm sorry, this is the changes that would occur in osteoarthritis, but it's of the actual synovial joint too. So the normal synovial joint, I take that back, is going to be on page 913 is the figure on page 179. And so this would be the normal synovial joint. And again, we're looking at the bone and the epiphyseal plates, the joint cavities, the synovial fluid that's going to help cushion, the articular cartilage, which is going to help keep it stabilized, as well as that joint capsule, which keeps it all together. So what about musculoskeletal diagnostic tests? Well, for bone disorders, we're going to use radiographs as well as bone scanning. Where for muscular disorders, we're going to use electromyography or EMGs or a biopsy. And then for joint disorders, you're going to use, again, the radiography, arthroscopy, the MRIs, or examination of the actual synovial fluid itself. And so moving on to some of the diagnostic things that we can look for, what happens if we have a fracture, right? Well, a fracture is a break in the integrity of the bone. And the fractures occur because of a trauma, from neoplasms, or from increased stress on the bones. And fractures are charted using the pound sign. And so I'm going to show you a picture. That's why I'm pulling up my phone. And this is figure 9.3 on page 167, okay? And this shows a fracture of the mid-shaft of the humerus. So I ride horses. I told you guys that. This last spring of 2020, I actually ended up fracturing my finger. So I can show you my picture. So you see this nice little fracture right here, this line. Yeah. So what happened is, as I was riding, the horse spooked and I flew off, right? And reins were wrapped around my fingers, and so my hand got caught in the reins, and it just pulled really tight, and so my finger's crooked because of it. This ring finger, you can see it's crooked right there. But yep, so that is a fracture. So it was not a complete, like, um, it wasn't like my hand was dangling, but I did have a fracture. So there was a break in the integrity of the bone. I had to be in a splint for a while until it fixed on x-ray. It looks like it's pretty good and calcified, but I still have a bump and it will never be straight again. So what about the classifications? We have complete, which means the bone is completely broken, and this forms the separate pieces. We have incomplete, and this is where the bone is only partially broken. You have open or compound fractures, and this is where the bone kind of sticks through your skin and the skin is broken. You have closed fractures, and this is where the skin is not broken. You have simple, and this would be a single break, and this maintains the alignment and the position. You have comminuted, and these are where we have multiple fractures and bone fragments. And you also have compression fractures, and these are where the bone is crushed or collapsed into small pieces. We also have other types of fractures, and again, this is on page 167 if you want to follow along. You have impacted fractures. This is where there is one end that's forced into an adjacent bone. You have pathologic fractures, and this results from weakness. You have stress fractures, which is from a fatigue of overuse and can cause it to fracture. You have depressed fractures, and this is where the skull, an example of a skull would be fractured and then forced into the brain. So that's not very good. You have transverse fractures, you have linear fractures. So the transverse is where you have the fracture feature across the bone. Linear fracture is the break along the axis of the bone. An oblique fracture is going to be the break in an angle of the diaphyses of the bone. And then you have a spiral fracture, and the fracture is a break that angles around the bone, usually due to a twisting injury. So here is a nice little summary of the different types of fractures, and this is figure 9.4 on page 168 of your book. So this would be kind of cool to draw these pictures or print this off and put them on a flashcard with the definition from the previous page 167 on it as a great study tool. So what about pathophysiology of the bone fractures? Well, the fractures are going to initiate an inflammatory response as well as a disruption in homeostasis. And so it can cause bleeding, it can cause swelling or edema, and that edema can cause a stretching of the periosteum if that periosteum is still intact, as well as the swelling of the soft tissues. And this can cause very severe pain. This fracture can release bradykinin and other chemical mediators, and this can also contribute to the pain. And we also have a clot that can form at the fracture site. And we can also, if it progresses enough, we can have systemic signs of inflammation that can occur. So how do these heal then? Well, the healing process is outlined on page 168. So first, we would have a hematoma, and this would be where the fiber network is going to be formed. Then the phagocytic, our little Pac-Man cells, are going to remove the debris that's there. Our fibroblasts are going to come in, and they're going to lay down new structure, right? They're going to lay down new collagen fibers. Then our chondroblasts are going to come in, and they're going to form new cartilage, okay? Then you have the formation of a procallus, which would be a fibrous collar. And then you can have those osteoblasts, which are going to generate new bone. And then the precallus is going to be replaced by bony callus. And then we have the remodeling of the bone. And this is when we would be able to return to use. So looking at figure 9.5 in your book on page 169, this is going to be the healing of the fracture. So up here in A, you can see that in the pink in the middle is the medullary bone marrow cavity. Then you have the red zigzag line here, and that's actually going to be the fracture, okay? And what it shows here is the red is the bleeding, which is where that the hematoma is going to form. And then down here, you have the necrotic bone is being reabsorbed. The clot is reacting to the fibrin mesh and the granulation that's occurring to the tissue. And you also have increased chondroblasts and osteoblasts that are going to be recruited to that area of injury. Then down here in C, you have where that procallus or the fibrocartilage collar is going to form. And then we have osteogenic activity, and this is going to be filling in that bone gap. Okay. Then down here in D, we have calcification that's going to occur, and you have that bony callus that's going to be formed. And then down here in E, you have the remodeling of the bone that's formed. And then down here, down in F, this is the actual healed bone back to as close as the original as we can get. So that would be the overall view of the healing of a fracture. So what about factors that can affect the bone healing? And this is on page 168 and 169. Well, basically, how bad is it, right? So the amount of local damage, if I broke my finger from a horse fall versus I got my hand stuck in a vice grip or something like that, they're going to be completely different healing things. Also, how close you are to the bone ends, whether or not there's the presence of a foreign material or infection. Mine was a closed fracture, right? So it just, no infection or anything like that. So that was good for me, right? Also, whether or not you have blood supply that is occurring or getting to the fracture site, as well as systemic factors such as age, nutrition, and anemia. So what about complications that can occur? And this is on the top right of page 169. Well, we can have muscle spasms, and these muscle spasms can occur as local pain and irritation causes strong muscle contractions at the fracture site. The muscle spasm can pull the bone fragments further out of position, causing angulation or deformity, the rotation of the bone, or overriding the bone pieces. Such abnormal movement of the bone causes more soft tissue damage, bleeding, as well as inflammation. You can have infections that occur, and some of these infections could be tetanus or osteomyelitis. And these are a threat in the people with compound fractures or when surgical intervention is going to be required. In these cases, precautions would include debridement of the wound, so cleaning it out, right? Application of the windowed cast, tetanus booster shots, and prophylactic antimicrobial therapy. You can have ischemia, right? And that would be a complication that develops in the limb following the cast treatment as edema increases during the 48 hours after the trauma, and the limb is going to be compressed by the cast. The peripheral area, an example of this would be like your toes or fingers. They can become pale or cold and numb because the peripheral pulse has decreased, and it can be absent, or it's likely that the cast has become too tight and it can be compromising the circulation of the blood. So we have to redo the cast in order to eliminate permanent damage. You can have a fat emboli, okay? And this would be, it's a risk where fatty marrow is going to escape from the bone marrow into a vein within the first week of the injury. The fat emboli are more common in patients with fractures of the pelvis or the long bones, such as the femur, particularly when the fracture site has not been well immobilized during the transport. There was also one that this list skipped. It was compartment syndrome, and compartment syndrome may develop shortly after the fractured bone when there's more extensive inflammation, as well as, and these examples of this can be like crash injuries or crush injuries, and increased pressure within the fascia and the non-elastic covering of the muscle that can compress the nerves of the blood vessels, causing severe pain, as well as ischemia or necrosis of the muscle. You can also have nerve damage, and this can occur with severe traumas or with a tearing of the periosteum. You can have the failure to heal or the development of a deformity that occurs during healing, and this is like if the bone is not stabilized with at the ends close together, then that can cause problems. Like this is a little bit off, and it's because there was really nothing you can do for a finger other than wear a splint, and I still had to work, and so I typed on it, and I tend to type on the outside of my finger, so I'm sure that that was me that did that. And then you can also have residual effects such as osteoarthritis. I still have pain in this hand. I probably always will from the fracture in the muscle pulling. So what about, this is where the compartment syndrome comes in. So the compartment syndrome we talked about a little bit, okay? And so the edema within one area of the compartment of the limb that's between the layers of the dense connective tissue or the fascia. This would be where we have ischemia and infarction of tissue, and this may occur because the compression of the arterial blood supply. That tissue may become gangrenous, and this may require amputation. And if it's too tight of a cast, then this can cause that compartment syndrome. So how do we treat fractures? Okay, well, this is on page 170 on the lower left. The first one is that you can have a controlled reduction, a closed reduction, and this is where we're going to have pressure or traction, right, in order to restore the bone position. So that would be like in a severe case. You can also have open reduction, and this would be surgery that you would need to align or insert pins, screws, rods, or plates in order to align those bones and keep them straight long enough in order to heal. What about dislocations? Okay, so dislocations is on page 170, and when you dislocate something, it's like you pop something out of your joint, or you dislocate your shoulder or whatever. This is where you have a separation of two bones at a joint with a loss of contact between those articulating surfaces. And this is usually accompanied by significant soft tissue damage to the ligaments and the tendons, and this can also distort the joint. And usually this is evidence, so it'll be like popped out. You can see it, so I can actually kind of disjoint my shoulder, one of my many talents, right? And this may recur repeatedly, sometimes often requiring surgery. So this dislocation is on page 170. It's figure 9.6, and this shows you that the bone is displaced out of the joint. So it's supposed to be up here and it pops down there, right? So that would be dislocated. What about sprains and strains? So this is on page 170. And so a sprain is a tear in a ligament, where a strain is a tear in a tendon. We have avulsion, and this is where the ligaments or tendons are completely separated from the bony attachments, and immobilization is often used to prevent the tissue damage and also to help promote healing. Okay, so this would be like putting your foot in a walking boot, right? So, been there too. What about other joint injuries? So this is on page 171. So what about overuse injuries? Well, this can cause muscle tearing. We have repetitive strain injuries, and these are injuries that develop over a period of time in which the same movement is repeated. And so, some of these injuries can be occurred from massage people, right? They're doing the same rubbing, massaging all the time. Keyboards and typing, clicking the mouse, right? So I hurt my hand with a horse, but I'm also right-handed. I'm on a computer I'm not 24/7 because I sleep, but for all of my jobs, right? And then also, running and jogging can cause some of these joint injuries as well. So how do we diagnose these joint injuries? Well, we can use the history of the joint use and any trauma that may have occurred to that area. You can have physical examination of the joint, including the range of motion that you have or don't have. You do radiography or do an MRI to see if there's more significant damage. And you can also do arthroscopes, and the arthroscopy can be done, and this can be accompanied by treatment to see how you are healing. So what about treatment of those joint injuries? Okay. So this would be using the Rice method of treatment. Okay. So Rice would be rest, immobilization, compression, and elevation. Okay. So if I sprain something, right, I'm going to want to raise my ankle. I'm going to want to rest on it and not really walk on it. I'm going to try to wrap it so it doesn't swell. Oh, have a case of the yawns. Okay, etc. And you can also use the NSAIDs, which are going to be non-steroidal anti-inflammatory drugs, right? And these can help with pain. You can also use physiotherapy, and so this can be, going to the physical therapist and, making sure that you can still maintain, movement of that area, etc. And then you're also going to want to possibly do the massage around the surrounding area so that you can, make sure that that tissue doesn't kind of not going to calcify, but then it doesn't like seize up and cause even more problems. So you're going to keep massaging that area so that we can keep it supple. So what about muscle tears? Okay. Well, muscle tears can occur as a result of trauma or overextension or overstressing that muscle. And repeated injuries will result in a fibrous scar tissue that can replace normal structures. And there are 3 different degrees of muscle tears. You have the first degree, and this would involve only a small percentage of muscle fibers. You have second degree, and this involves much of the muscle, but it's not a complete tear. Then you have third degree, and this is a complete tear across the width of the muscle. And you can find these muscle tears on page 171 to talk about a little bit further. Moving on to bone disorders. Well, osteoporosis, right? We talk a lot about osteoporosis. We don't, but the news and the media does, because this is becoming pretty common, okay? And so this would be where you have a decrease in bone mass and density, and this can occur in 2 different forms. The primary form would be idiopathic, and this is just age-related, and it usually occurs in 50 years and older of age. This is a result of sex hormones that are decreased, as well as the decreased calcium intake. And you also can have secondary, and this can be due to a complication or of another disorder. And osteoporosis and bone disorders are discussed on page 172. The pathophysiology of osteoporosis is that the bone reabsorption is going to exceed the formation. And so we're like kind of pulling apart our own bones. And this results in the loss of that compact bone tissue. And this can be diagnosed with bone density scans. We can use, this can cause compression fractures of the vertebrae, of the wrist, and of the hip. And this can lead to kyphosis and scoliosis as well. What are some of these predisposing factors? Well, age is one of them, one of the main ones. And this is, these occur in the 50 and above year population. This can cause decreased mobility or be because of decreased mobility or a sedentary lifestyle. You can have hormonal factors that are going to play a role in those, where you have excess corticosteroids or a parathyroid hormone, which is abbreviated PTH. You can also have a deficit of estrogen or testosterone. And these deficits of calcium, vitamin D, or protein can also cause, this osteoporosis. Cigarette smoking. If you have a small, light bone structure, so for instance, if you are Asian or of European ancestry, they tend to have very dainty and small bones, and this can be one of the predisposing factors. And also, if you have excessive caffeine intake, that can cause some issues. So how do we treat this? Well, through dietary supplements, through fluoride supplements, through bisphosphates, through calcitonin, human parathyroid hormone, weight-bearing exercises to strengthen those bones, rallofloxacin and tamoxifen, right? Other medications are still in like the treatment or in the investigation stages, but we have other treatments that are currently being sought out. And then, worst case scenario, we can also have surgery to reduce those kyphoses. So what about muscular dystrophy then? Well, this is a group of autosomal recessive disorders, and we talked a little bit about the genetics of this last week, and this is on page 175. And so muscular dystrophy is going to be the degeneration of skeletal muscle that occurs over time. And Duchenne's muscular dystrophy or pseudohypertrophic muscular dystrophy are the most common types, and these can affect young boys over young women. So for signs and symptoms with Duchenne's muscular dystrophy, this is where you're going to start demonstrating early motor weakness. You have a weakness in that pelvic girdle area, and this causes a waddling gait, and it can cause difficulty in climbing stairs. You can have a Gower maneuver, and this is pushing up to an erect position. And this is demonstrated in figure 9.9. There's a little girl that's showing the Gower movement and how they're pushing up off the floor into a standing or erect position. You have the tendon reflexes that can be reduced. You have deformities that can develop, such as kyphoscoliosis. You have respiratory infections that are very common, and then cardiac myopathy can also commonly occur. So how do we diagnose these? Well, first we're going to be identifying common genetic abnormalities, and these are going to cause elevated creatinine kinase levels. You can diagnose it through electromyography. You can diagnose it through muscle biopsy, and also blood tests that can show abnormal dystrophin levels. So unfortunately, there's no curative treatment. It's just palliative. Okay. So some of the things that you can do to help out, it would be moderate exercise to maintain the motor function, and also supportive appliances such as braces. You have physiotherapy and occupational therapy that can happen to help maximize the function and adaptation to the new restraints. You can do massages, and this can help to reduce pain as well as stiffness. In really bad cases, you may have to go on a ventilator, and this would be, of course, in the case of respiratory failure. And there's a lot of research that's still being done on genetic therapies, and hopefully in the future, pharmacogenetics will be very strong, and we can take this more on like an aggressive treatment. So with the types of muscular dystrophy, this is table 9.1 on page 175. And so you have your Duchenne's, the inheritance, the age where it is onset, distribution, i.e. where it's manifesting itself, and then the progression. So this is a great summary table as well. So what about joint disorders? Well, we have osteoarthritis, okay? And joint disorders are talked about on page 176. Osteoarthritis is degenerative. And so this is a wear and tear joint disease. And this may be the result of increased weight bearing or lifting. You can also have, we also are seeing the incidence of osteoarthritis is increasing. And there is a genetic component that is being identified in research with mice, but it hasn't been identified yet in humans. So what is the pathophysiology? Well, the articular cartilage is going to be damaged, and then the surface of the cartilage is going to become rough and worn. And the tissue damage causes the release of enzymes, and these can accelerate the disintegration of that cartilage that is left. You can have some subchondral bone, and this may become exposed, and cysts, osteophytes, or new bone spurs may develop. Okay. Osteophytes and the cartilage can break off, and then that joint space between the bones becomes narrower. And then a secondary inflammation from both of these can occur in the surrounding tissues. And then this can occur or can cause a loss of normal range of the joint motion. And then this obviously is going to cause a lot of pain with weight bearing and use. So what about pathologic changes with osteoarthritis? This is going to be figure 9.10 on page 177. So you can see here that you have the cyst that's going to occur in the bone. You have the osteophyte or the bone spur that can occur. You have the narrowing joint space. So those are going to be rubbing up on each other, and that's going to cause pain. You have the cartilage fragments that broke off that can again get stuck, or they can just rub up against things, and that can be very painful. Then you have the erosion of the cartilage in the bone that can cause those cartilage fragments. So what about the etiology? Okay, well, the primary form is going to be from weight bearing, from obesity, and from aging. But we do have secondary forms, and this can be following a trauma or from repetitive use. Genetic factors are also thought to play a role, and weight-bearing joints are most frequently affected, but finger joints are also affected. Some of the signs and symptoms are going to be an arching pain with weight bearing and movement. You have limited joint movement. You have recreational and social activities that become very limited because of the pain. When you're in pain, you're not going to want to do them. Walking can become difficult. You can have a predisposition to falls. You can have TMJ or temporomandibular joint syndrome, and this is severe pain in your jaw, right? And they can dislocate and just cause like a clamping, right? Mastication, which is a fancy word for chewing, and speaking can be difficult. And you can also have a bony enlargement of the distal interphalangeal joints. So how do we treat this? Well, we stress on joint minimization by use of adaptive devices such as a cane, right? You're going to do pacing activities. So instead of walking a mile at a time, just do a couple of steps, rest, steps, rest, or like if you're doing laundry, make it a 3-day thing instead of a 1-day thing. You can pace things out. We want to do mild exercise programs to help maintain fitness and joint function. We also want to have supports such as hand braces to help facilitate movement. And many times you're going to have orthotic inserts in your shoes to help with angles as well as stability. Massages work, physiotherapy, acupuncture, occupational therapy, glucosamine, chondroitin supplements, injection of your synthetic synovial fluid, which would be your hyaluronic acid into those synovial areas, NSAIDs, which are those pain relievers, analgesic, which is like also a pain number, arthropathy, which is you can use to stabilize the joint, and also surgical joint replacement. So moving on to another very common disease, and this would be rheumatoid arthritis. And this is considered to be an autoimmune disorder, and this is covered on page 178. And this causes chronic systemic inflammatory diseases, and it has a higher incidence in women than it does in men, but it does affect all age groups. Interestingly enough, I have an aunt that has rheumatoid arthritis, and then her child had it but outgrew it. So the pathophysiology of it is we have synovitis, and this would be, itis is an inflammation of what? The synovial area. So this would be marked inflammation, and then cell proliferation that occurs. You have a pannus formation, and this would be where you have a granulation tissue that is going to be spreading. You can have cartilage erosion, and this is going to create an unstable joint. You can have fibrosis, and this is where you would calcify and obliterate the joint space that would be there. And then you can have ankylosis. Oh my Lord, I can't say that. Ankylosis. And this would be where you have joint fixation and deformities that can develop if they are left untreated. Other changes that can occur are, they frequently would occur around those joints, and it can cause the atrophy of the muscles. It can cause bone alignments to shift. It can cause muscle spasms caused by inflammation as well as pain. And this can also have contractures, right, of the hand and deformity that can develop. Looking at the cardiologic changes in the rheumatoid arthritis joint, you can see one here is the inflamed synovium. So that's a synovial fluid space that's going to be inflamed. You have the pannus that's going to be there. You have a loss of cartilage that you can see here. You have fibrous tissues that can grow. Then you have the pannus-filled erosion that also can occur. This is figure 9.14, and this is the typical deformity that is seen in a hand with rheumatoid arthritis. Okay, you have your Bolsonaire deformity, that is the location of your ulna. You can have a linear draft off to the side. Then you can have the deformity and ankylosis of the joint that occurs. What causes it? Well, we don't exactly know, okay? But we do know that there is a genetic factor that is present, and that there is a familial predisposition. If a family member has it, you have an increased chance that you would, someone else in the family would have it. And some can link this to some viral infections. What are signs and symptoms? Well, inflammation in that occurs first in the fingers or the wrists. The joints can become red and swollen, and they can be sensitive to the touch as well as be very painful. They can cause joint stiffness. The joint movement can be impaired. You can have malocclusion of the teeth that can develop from the TMJ involvement, as the condyle is going to be damaged. Some effects can be, you can be very, very tired. You can be depressed. You can overall not be feeling well. You cannot want to eat. You can have a low-grade fever. And this can also cause iron deficiency anemia that is resistant to iron therapy. So a lot of things can happen. Well, how do we treat this? Well, we want to balance between rest and moderate activity, heat and cold applications, varying physical and occupational therapy, those NSAID drugs. Glucocorticoids can be used for the severe inflammation. We can use analgesics for pain. We can use disease-modifying anti-rheumatic drugs, such as gold salts, methotrexate, and hydrochloroquine, right? Hydroxychloroquine. We can also use biologic responses, such as modifying agents, such as infliximab, ribulabib, and anilcarya. I just butchered those pronunciations. What about juvenile rheumatoid arthritis, otherwise known as JRA? Well, there are several different types of these, and the onset is more acute than the adult form, and the large joints are going to be the ones that are frequently affected. So, this is the still disease, or the systemic form. It would cause fever, rash, like problems with your lymph nodes, problems with your kidneys, and your joint involvement. A second form of JRI can also cause polyarticular inflammation, and a third form of JRA involves 4 or fewer joints, but it can cause uveitis, which would be inflammation of the iris, the ciliary body, and the chondroid of the eye. All right, so I will see you guys in class. See you later.